Just like to thank Jim and the team for inviting me to speak today. A very important topic. And I'm been invited really to talk about similar efforts in Scotland to take our research and get it implemented into policy and practice. Today I'm going to talk about the current challenges and the state of play in the Scottish context, how we've been trying to build a world-leading health and well-being research ecosystem, and this is through data-driven innovation, and also how we might then go on and maximize the opportunities and benefits from the great data resources we have in the UK. What are the challenges? Well, I did my PhD in asthma research in 2003, so approaching 2 decades ago. And since that time, we produced many guidelines and carried out a tremendous amount of really good high quality research to try and improve asthma management. So why do we want to improve asthma management? Well, good asthma management will prevent individuals with asthma from having asthma attacks and stop them going into A&E and being hospitalized. And so it's very simple. We actually have some effective levers to stop this from happening. One of them is having action plans for guided self-management. And we've known this for a long time. But this is the current state of play. Well, this is data that we're able to extract from Scottish primary care. We have the systems to be able to extract from, at this point in time, 300 practices, and now we're able to extract from individual patient data from every practice in Scotland. So that's around about 950 practices. But this gives us a really good national picture on how our patients with asthma are treated. So this is looking at just over 100,000 people with asthma. It looks at whether they've had these unscheduled contacts, and we have a good look at how they're being managed in primary care. Now, everybody should have had their inhaler technique reviewed. So looking at inhaler technique, everybody with asthma, and a good majority, should have an inhaled corticosteroid, and actually we're doing quite well on that. So this is line 33, so 70%. But then when it comes to medication review and self-management plans or action plans, the percentage is in fact very low. So the picture hasn't really moved on in 2 decades. So we're not really implementing our research into practice. Can we be optimistic? Well, yes, we can. Data is increasingly recorded on more effective electronic medical systems. And these are largely cloud-based now. So data repositories are now available. And these include millions of observations and treatment decisions, and particularly from primary care. Very beneficial to us and in Scotland is that we have unique patient IDs. So the CHI number and the NHI number. So every single health contact in Scotland, there's an NHI, a CHI equivalent. And so we're able to track patients in time and over the entire healthcare system. So the CHI allows us to link all these different data sets. So the current state of play in Scotland is, yes, there's a lot of data generation. We have some great longitudinal surveys like national health surveys. We have birth cohorts, bespoke data collections and registries. We also have some tremendous routinely collected data through the national data collections, which includes hospitalizations and primary care data. So we're really good at assembling data. We can take research topics and analyze how we might get better care or better health outcomes for our patients. And we do our interpretation. So are these results credible? What actions should we take? And this is a sort of fundamental building blocks of a learning health system. We call this data to knowledge. So data to knowledge, it can produce great data. We can produce great data. We have high quality analytics, and that leads to national stats, published papers and guidelines. We can answer practical questions, for instance, about our interventions, whether they're safe, effective, We can look at the value of healthcare services. However, as been alluded to before, the implementation of findings via policy or practice is delayed. And in fact, the average impact of research in health is 10 to 20 years from paper to clinical practice or policy. So where do we want to get to? Well, we want to produce a learning health system that moves beyond data to knowledge, completes a data generation analytics cycle. So we want to move from knowledge to performance and performance to data. So knowledge to performance is, for instance, producing algorithms that drive real-time decision support from our front-end clinicians. We can produce timely, tailored feedback to clinical staff that they can action on. And we can also provide near real-time feedback to policymakers so they can watch policy come into action. And then the most important part of closing that feedback loop is performance to data. So if we have the data systems, we can actually measure the reactions in response to that feedback. And we can see whether we need to, for instance, collect new data or carry out new analytical approaches. So it's an iterative approach that makes the system run more smoothly and provides better high value information to our staff and policymakers. So we've attempted to build such a platform in Scotland, and that we brought together a number of multiple funders and organizations, and we wanted to lay the foundations for learning health systems. And in 2009, the Scottish Informatics Programme was funded. And this was to exploit our ability to link data. A crucial part was to try and declutter the pathway for regulation, in particular around health data research. And we wanted to move towards a proportionate approach to research governance. We wanted to deliver collaborative arrangements with industry and position Scotland as a single research site when it makes good sense to do so. And this was because in Scotland, everybody was working in silos. So universities were working on their own, not talking to each other, and the same with the health boards as well. So a lot of great work was being carried out, but no one was really speaking to each other. So this is an attempt to unify. In 2012, the FAR Institute ended, the funding ended, and the FAR Institute managed to get 5 years of funding. And this was to take the Scottish part and actually maximize it across the UK. So again, similar things, which was enhancing our health data sets and our health linkage, collect data, and so forth. And really importantly, in the Scottish context, we had the Electronic Data Research and Innovation Service set up. And this service is there to help our researchers and provide expert advice, assisting in what data is available and looking at strengths and weaknesses of our data, do liaising with and creation of building important relationships, including with internal and external partners, and really navigate that very complex data landscape. So Aegis was really good at trying to get your permissions. So what was great about it, and this is where FAR Institute funding was so crucial, was we were able to get a research coordinator to help us with that navigation, so support us with all these privacy and information governance applications. We also had set up a new panel which solely dealt with health research, and this was a public benefit and privacy panel for health and social care. And this was a one-stop shop for that proportionate governance permission. So it was very easy, both for government and for academia and actually for industry, to go to this panel and actually seek permission. So a very slick process that ensured that the research was carried out in a good manner. This is the kind of permissions and agreements landscape that you have to navigate, and particularly when you're not using health data, so you want to add other data sources like census or schools data. And there were other Aegis functions which were very helpful. So they carried out, once you got your permissions, they carried out indexing and linkages, they advised on software licenses, arranged delivery of data, provided a secure environment. So we had a unified national safe haven and trusted research environment. So this is a place you went to for your health research, so no silos. And a disclosure service, so actually they provided disclosure on your outputs. And actually, if you wished, you could also get analytical support. So that funding for our institute ended in 2018. And one step further, the Health Data Research UK was set up. Now, this was actually became a funding organization. And this new source of funding created hubs which were based on disease and methods focused. And these 8 hubs were set up. And I was involved in the Breathe Hub, which is based at University of Edinburgh, where I have an honorary fellowship. And Breathe focused on respiratory disease and became the UK data gateway and trusted research environment for respiratory disease. But in 2020, of course, COVID-19 comes along, and this provides rapid acceleration of this kind of research because we desperately needed this data and very quickly. Policymakers were crying out because this is a new disease and we knew nothing about it. And part of my work was to look at COVID-19 vaccination and look at effectiveness of the vaccination program at the earliest point that we could. And so we were able to deliver on the back of the safe havens and this EDRIS support system. We were able to deliver evidence in February, and the 2021, the vaccination program started in earnest in December 2020. Very crucially, this information was changed policy and practice. So clinical trials suggested 3 to 4 weeks after first dose to receive second dose. What we found was that 6 to 7 weeks after first dose, effectiveness of the vaccine against COVID-19 hospitalization remained high. And this was prior to the Delta era. So what that meant was that the policy change was that we would maximize and focus on upping the uptake in first doses and focus on second dose further down the line. So it's really to get the population, as many populations with a single dose, single jab as possible. So I guess it just accelerated this aspect of putting in this information, this back into policy, back into clinical practice very, very quickly. So it really focused mine. So we had the system to be able to deliver that. So do we have similar challenges in New Zealand? Well, yes, we do. Asthma management, going back to my beginning slides, is also not great here. So this is only 36% of people admitted with asthma were not regularly dispensed, inhaled corticosteroid. Sorry, 36% of people admitted with asthma were not regularly dispensed inhaled corticosteroid. So this 36% of people are likely to come back in with further hospitalizations. So the future directions for us could be, well, we have actually very good data sets within the health and well-being data ecosystem. So we have the IDI, we have fantastic longitudinal cohorts, and the Ministry of Health also has great health data sets. But can we develop the new platforms and methods to improve timeliness of data provision and the ease of access? How do we speed up the process of access and analysis and help with rapid knowledge translation? And can we do this in a privacy preserving way with adequate social license? So we want to move beyond the data to knowledge and go to knowledge to performance and performance data and close this feedback loop. I'd just like to acknowledge my collaborators and funders and thank you for your time.